Hey there, and welcome. Today, we're going to unpack a feeling that, let's be honest, millions of us know all too well. That uncomfortable, burning sensation in the chest. What is it really? And what's actually happening inside our bodies? Let's dive in and find out.
You know the one. Maybe it's after a big meal or when you lie down for the night. And there it is, that rising, burning feeling. We usually just call it heartburn. But what's really going on inside to cause that sensation?
Well, that feeling has a medical name, Gastroesophageal Reflux Disease, or just GERD for short. And what that really means is that the powerful acid that's supposed to stay in your stomach is flowing backward up into your esophagus. That's the tube connecting your throat and your stomach.
But, GERD isn't just about that one single burning feeling. It's actually a condition with a whole cluster of symptoms that tell a much bigger story about what's happening.
So, the classic symptom, the one we all know, is heartburn, that burning right behind your breastbone. And it often feels way worse when you lie down because, gravity isn't helping you out anymore to keep that acid down. Other common signs? Regurgitation or a sour taste in your mouth. And in some cases, people even get something called dysphagia, which is just a medical way of saying they have trouble swallowing. That can start out as a spasm but can get more serious over time.
So why does this happen? What causes that natural valve system that's supposed to protect us to just fail? Well, for most people dealing with chronic reflux, the answer isn't really about what they ate. It's a specific mechanical problem inside the body. And the main culprit, by far, is a condition called a sliding hiatus hernia. This is the #1 reason people get chronic GERD, and really it all comes down to a pretty simple mechanical failure.
And look at these numbers. They really tell the whole story. About 95% of all these hiatus hernias are the sliding kind, the one that's directly tied to GERD. The other type, a rolling hernia, is way less common.
So here's the key difference. With a sliding hernia, the spot where your esophagus meets your stomach literally slides up into your chest. This messes with the natural valve that keeps acid down, which leads directly to reflux and all those GERD symptoms. Now, with a rolling hernia, that junction actually stays put, but a part of the stomach bulges up next to it. This usually doesn't cause reflux, but it can create a lot of painful pressure and sometimes needs surgery to fix.
Okay, so let's say you go to the doctor for these symptoms. How do they figure out what's really going on in there? Well, they've got a standard set of tools they use to get a crystal clear diagnosis.
These are the big three. The gold standard is 24-hour pH monitoring. Basically, a tiny probe measures the actual acid levels in your esophagus for a whole day. Then there's an endoscopy, where they use a tiny camera to literally look inside your esophagus. And finally, a barium swallow is a special X-ray that can show the reflux happening in real time. Pretty cool, huh?
So when they're in there with that camera, doctors are looking for any damage from the acid and they grade it on a scale. It might just start as some simple redness in grade 1, but it can progress to ulcers. By the time you get to grade 4, the damage is pretty severe, leading to things like a stricture, which is a narrowing of the esophagus, or a condition we're going to talk about in a minute called Barrett's esophagus.
Okay, but the good news, and there is good news, is that once it's diagnosed, there's a very clear, well-established path to managing GERD and finally getting some relief.
The very first line of defense is always lifestyle changes. Things like reducing weight can lessen the physical pressure on your stomach. Eating smaller, more frequent meals means your stomach isn't making a huge batch of acid all at once. And honestly, simple things like avoiding trigger foods and not eating right before you go to bed can make a massive difference.
Now, if those lifestyle tweaks don't quite cut it, there's a ladder of medical therapy. It starts simple, with things like antacids for mild cases. The next step up are H2 blockers, which actually reduce how much acid your stomach makes. And for the really persistent cases, the most effective meds are proton pump inhibitors, or PPIs, which are really good at shutting down acid production.
But I really want to stress this. Surgery is not where this usually ends up. For the vast majority of people, we're talking 85 to 90%, those lifestyle changes and medications are totally enough to get GERD under control.
Now, for that small group that does end up needing surgery, the most common procedure is called a fundoplication. Basically, what the surgeon does is pretty clever. They wrap the top part of the stomach around the lower esophagus to create a brand new, stronger valve that physically stops the acid from coming back up.
Okay, so what about the long game? Why is it so important to get chronic reflux under control? Well, this brings us to the most serious potential complication of GERD.
It's a condition called Barrett's esophagus, and it can develop after years and years of acid exposure. What's happening is actually kind of wild. To protect itself from the acid, the body literally changes the cell lining of the esophagus to be more like the tough lining of the stomach. Now here's the catch. While this new lining is protective, those new cells carry a higher risk of becoming cancerous down the line.
I know that sounds pretty scary, but the key here is not to panic. The risk is actually very manageable with a really clear and simple surveillance plan. It's all about monitoring.
And this is what that plan usually looks like. It's pretty straightforward. After the initial diagnosis, if no precancerous cells are found, it's just a matter of getting a follow-up endoscopy every 3 to 5 years. For most people, it just becomes a long-term, routine checkup. And look, even if they do find some changes, there's a whole range of treatment options. It starts with continued checkups and strong acid-suppressing medicines. There are even advanced therapies that can remove the abnormal cells right through the endoscope. Major surgery to remove the esophagus is a true last resort, only for the most serious cases.
So, what's the big takeaway here? That burning feeling, it's not just some random annoyance. It's a signal from your body. And understanding what that signal means is the absolute first step toward taking control and managing your health, from simple lifestyle changes all the way to long-term monitoring.
So that discomfort, the one you might just be brushing off, it could be a really clear message. The only question is, are you listening?
And of course, just a friendly reminder, this explainer is for informational purposes only. If you're experiencing any of these symptoms, please talk to a healthcare professional to get a proper diagnosis and a treatment plan that's right for you. Thanks for joining me.
Welcome back to the deep dive. If you've ever had that nagging burn right behind your breastbone, maybe after a big meal,
A dull fire, yeah.
or maybe you've woken up with that really sour, almost metallic taste. You know exactly what we're talking about today.
Yep.
Chronic acid reflux.
That pain, the retrosternal pain and the regurgitation are incredibly common. But, when it becomes persistent, when it really starts messing with your daily life, that's when we call it GERD, Gastroesophageal Reflux Disease.
GERD, right.
And technically, it's the chronic reflux, the flowing back of acidic stomach contents into the lower esophagus.
Okay, so today we're definitely going beyond just the symptoms. Our mission here is to do a deep dive into the underlying structural problem that often drives this persistent GERD. We're talking about the hiatus hernia.
Yeah, these two get confused all the time.
They do, but our sources really lay out a critical difference, a distinction that completely changes how you approach treatment.
That's absolutely right. And this is maybe the most important thing to take away today. There are basically two main types of this hernia.
Yeah.
One type, it's pretty much the main reason people get reflux and GERD.
Okay.
But the other type, while it can actually be much more dangerous mechanically, it causes absolutely no reflux symptoms. None at all.
Wow. So understanding that structure, the geometry, really determines what needs to be done.
Exactly. It dictates the whole path forward.
Okay, let's unpack that. Let's start with the common side, with GERD itself. The main cause, according to the material we looked at, is what's called a sliding hiatus hernia.
Check one.
Right. And it's made worse by basically anything that jacks up the pressure inside your abdomen. Could be weight, pregnancy.
Even just wearing really tight pants sometimes.
Right. You're literally squeezing your stomach contents upward.
And the classic symptoms reflect that physics perfectly. The heartburn. It typically gets worse when you lie flat.
Because gravity isn't helping keep things down anymore.
Exactly. And it often feels better when you stand or sit upright. Regurgitation is also really common, especially lying down. That's what gives you that horrible sour taste.
And if this goes on unchecked, the sources say people can start having trouble swallowing. Dysphagia.
Yeah, dysphagia. Initially, it seems like it's often just the esophagus spasming, trying to clamp down and protect itself from all that acid.
Like a defense mechanism.
Kind of, yeah. But it's temporary. Over time, that constant acid bath causes actual damage, scar tissue forms, and that leads to something much more serious, a stricture.
Meaning the esophagus actually narrows permanently.
It can, yes. It physically tightens up.
So GERD isn't just you have it or you don't. There's a progression here. And doctors actually grade how bad it is.
We do, yeah. Clinicians often use endoscopic grading systems like Belsey's grades to see how severe the esophagitis, the inflammation is. It's a spectrum.
Okay.
Grade 1 might just be some redness, what we call hyperemic mucosa, but it can progress all the way up to grade 4.
And grade 4 is bad news.
Grade 4 means you've got a significant stricture Or, and this is really critical, you've developed Barrett's esophagus.
We'll definitely come back to Barrett's. That sounds serious.
It is. It's precancerous. So the grade tells us, how far things have gone and how urgent the intervention needs to be.
And this is where it gets, well, kind of wild. These late-stage problems, they don't just stay in the esophagus, do they? If GERD is bad enough.
That's right. The damage can spill over, so to speak. You can get aspiration pneumonia if acid gets into the lungs.
Wow.
Or chronic laryngitis, maybe just persistent hoarseness. It's because that acidic mist is literally creeping up into the airway.
Okay, that makes sense.
Yeah.
But the big one is Barrett's.
Absolutely. Barrett's esophagus is the most concerning long-term complication of GERD. It's where the normal lining of the lower esophagus, which should be flat, squamous cells, it changes. It morphs into a different type of tissue, columnar epithelium. It's called columnar metaplasia.
So the tissue is trying to adapt to the acid.
It's trying to protect itself, yeah. But that change, that adaptation, makes it a precursor for adenocarcinoma, a specific type of esophageal cancer.
Right. The stakes are definitely high. Okay, now that we've got a handle on GERD's severity, let's dive into the root mechanical cause you mentioned, the hiatus hernia.
Okay, so fundamentally, a hiatus hernia means some part of the stomach is pushing up through the diaphragm.
Through that opening where the esophagus normally passes through. The hiatus.
Exactly, the esophageal hiatus. Now, sometimes it gets broken down into 4 types, but for understanding the core problem, we really need to focus on the 2 main mechanical setups.
And those are type 1, the sliding hernia.
Which is like 95% of cases, super common.
And type 2, the paraesophageal hernia, sometimes called a rolling hernia.
That's right, rolling. And these 2 are just structurally and symptomatically, they're worlds apart.
Okay, let's break down type 1 first. The sliding hernia, the GERD culprit, you called it.
Right. So in a sliding hernia, the very top part of the stomach, the cardia, herniates. It pushes up above the diaphragm. And crucially, the place where the esophagus joins the stomach, the GE junction, that also slides up into the chest.
Wait, so normally the diaphragm muscle itself helps keep the acid down, like a valve.
It plays a huge role. The diaphragm muscle pinching around the esophagus, plus the angle it enters the stomach, creates what we call the high pressure zone. Think of it like a natural clamp or maybe a specialized one-way valve. It keeps the pressure higher in the esophagus right at that junction, preventing backflow.
But if the whole junction slides up,
the clamp is gone, the mechanics are disrupted, that high pressure zone is lost or at least severely weakened.
then boom, acid reflux, gravity and abdominal pressure just push stomach contents back up.
Precisely. That loss of the high pressure zone is the direct cause of the acid reflux and the resulting esophagitis. So if you have a sliding hernia, your symptoms are typically classic GERD, heartburn, regurgitation. It's a functional failure of the valve.
Okay, crystal clear. Now let's completely flip to type B or type 2, the rolling or paraesophageal hiatus hernia. You call this the mechanical hazard.
Yeah, this is a totally different beast. The absolute crucial difference here is that the GE junction, where the esophagus meets the stomach, it stays put. It remains fixed in its proper anatomical position below the diaphragm.
Okay, so what herniates then?
What happens is a pouch of the stomach, usually the upper part called the fundus or the greater curvature, it kind of rolls up alongside the esophagus through the hiatus into the chest. It forms a separate hernial sac next to the esophagus.
But the valve, the GE junction, is still in the right place.
Exactly. The valve mechanism itself is intact. It hasn't slid up.
So what does that mean for symptoms if the valve works?
It means there is no inherent reason for GED. There's no structural failure causing reflux. So you typically get NO reflux esophagitis.
Oh, so what kind of symptoms do people get then?
The symptoms are purely mechanical. They're caused by the physical presence of that stomach pouch up in the chest, pressing on things.
Like what?
Like intermittent difficulty swallowing because the pouch might kink the esophagus, or pain after eating as the pouch fills up, even shortness of breath, dyspnea.
Because it's pushing on the lungs.
Or the heart leading to palpitations. Sometimes even persistent hiccups because the diaphragm itself is irritated by the hernia sac.
That's so different. And potentially misleading if you're expecting heartburn.
Totally misleading. But the real danger here is acute. It's sudden. Because you have this pouch of stomach that's kind of folded and potentially twisted, the biggest risk is strangulation.
Meaning the blood supply to that trapped part of the stomach gets cut off.
Exactly. That's a surgical emergency. Strangulation leads to tissue death, necrosis. The stomach pouch can rupture.
and leak stomach contents into the chest cavity.
Right into the mediastinum. That causes mediastinitis, which is often fatal. So even though this type 2 hernia is way less common, maybe less than 10% of cases,
It's potentially much more dangerous acutely.
far more dangerous acutely. It needs completely different management because of that risk.
Okay, that distinction really does change everything. So diagnosis must be key to figuring out which path to go down. If doctors suspect one of these problems, how do they know for sure which type it is?
Well, if the main complaint sounds like GERD, suggesting a functional problem like a sliding hernia, the gold standard test is actually 24-hour ambulatory pH monitoring.
Where they measure the acid.
Yeah, they place a tiny probe in the esophagus that measures the actual amount of acid refluxing over a full day. It quantifies how bad the functional failure is.
But if they need to see the structure, especially if they suspect a hernia, I thought this detail from the sources was amazing about radiology. The barium swallow.
Ah, yes, the barium swallow and meal. To really visualize reflux or see that bulge of a sliding hernia above the diaphragm.
You have to put the patient head down, the Trendelenburg position.
You got it. It sounds strange, but it's a clever mechanical trick. You use gravity deliberately against the normal flow to make the stomach contents reflux, or to make the hernia bulge more obvious on the x-ray. It helps confirm the physical defect.
That makes sense. And endoscopy.
Endoscopy is crucial too. You get a direct look inside, you can see the inflammation, grade the esophagitis, take biopsies.
And check for Barrett's.
And definitely check for Barrett's or other complications. It's essential for both diagnosis and ongoing monitoring.
Okay, let's talk treatment. For most people, the ones with the common sliding hernia and GERD, the first approach is conservative, right? Tackling those pressure factors.
Absolutely. Lifestyle changes are the cornerstone. The sources really hammer this home. Weight reduction if needed, eating smaller, more frequent meals.
And definitely not eating right before lying down.
Crucial. Avoid eating for maybe 2-3 hours before bedtime. And then there's avoiding the triggers that relax that lower esophageal sphincter, that valve.
Right, things like smoking.
Nicotine is a big one. Alcohol, caffeine, chocolate, even spicy foods for some people. Anything that makes that valve floppy.
And if lifestyle isn't enough, then drugs.
Then you move to medications. You usually start simple with antacids for very mild occasional symptoms.
Like Tums or Rolaids.
Yeah, things like that. Then you might escalate to H2 blockers. Things like ranitidine used to be common, though there are others now. They reduce acid production.
And for more severe, chronic cases.
And then you bring out the big guns, the PPIs, proton pump inhibitors, like omeprazole, lansoprazole. They're very effective at shutting down acid production.
Okay. Now, you said most people don't need surgery for GERD.
That's right. Despite how common GERD is, probably only 10 to 15% of patients end up needing an operation specifically for reflux.
But when they do, what's the goal?
The goal is anti-reflux surgery, to basically reconstruct or reinforce that failed valve mechanism. The classic operation is the laparoscopic Nissen fundoplication.
Fundoplication. We're wrapping the stomach.
Yeah, you take the top part of the stomach, the fundus, and wrap around the very bottom of the esophagus, creating a new, tighter valve. Usually done laparoscopically now, minimally invasive.
But I remember the sources mentioning a downside, that sometimes the wrap is too tight, causing difficulty swallowing.
Exactly. Post-operative dysphagia is a known complication of the standard Nissen. You fix the reflux, but now the patient struggles to get food down.
Not ideal.
Not ideal at all. So that led to modifications like the floppy Nissen, which is a looser wrap, or the toupee fundoplication, which is only a partial wrap. They're designed specifically to try and prevent that post-op swallowing difficulty.
Okay, makes sense. But, and this is the core insight, again, the treatment approach does a complete 180 for that dangerous type 2 rolling hernia, doesn't it?
Complete 180. For the paraesophageal, the rolling hernia, surgery is almost always necessary, and often pretty urgently, sometimes even if the patient has few symptoms.
Why? Because of the strangulation risk.
Precisely. You're not operating because of chronic acid damage. You're operating to prevent that potentially catastrophic acute complication of strangulation and rupture. The goal is purely mechanical: reduce the herniated stomach pouch back into the abdomen, repair the hole in the diaphragm, sometimes reinforcing it with mesh.
Totally different rationale. Okay, before we wrap up treatments, let's quickly revisit Barrett's esophagus, because managing that is long-term and crucial given the cancer risk.
Right. So Barrett's, as we said, is that change in the esophageal lining, the columnar metaplasia. Management has two main arms. First, aggressive, usually lifelong acid suppression with PPIs to minimize further damage.
Yeah.
Second, surveillance. If the Barrett's tissue doesn't show dysplasia, meaning the cells are changed but not yet developing cancerous features, then you need regular checkups. Periodic endoscopy, maybe every 3 to 5 years, to keep a close eye on it.
If they do see dysplasia starting, signs it's progressing towards cancer.
That's when you intervene more actively, often with endoscopic therapies, things like photodynamic therapy or radiofrequency ablation.
What do those do?
They essentially use light-activated drugs or heat energy to carefully destroy or ablate that abnormal Barrett's lining, layer by layer. The idea is to remove the precancerous tissue before it can become a full-blown adenocarcinoma.
Wow. It really highlights just how damaging that chronic acid exposure can be over time.
It really does.
Okay, we've covered a lot, the structures, the symptoms, the treatments, the key differences. I wanted to end our deep dive today with one last kind of surprising medical detail mentioned in the sources. Something called Saint's Triad.
Ah, yes, Saint's Triad. It's this interesting, specific medical observation where 3 seemingly unrelated conditions tend to show up together in the same patient more often than you'd expect by chance.
And those 3 are?
The triad consists of cholelithiasis, which is gallstones,
Okay.
hiatus hernia, which we've just discussed,
Right.
and diverticular disease of the colon, those little pouches that can form in the large intestine.
Gallstones, hiatus hernia, and colon diverticula. Why on earth would those 3 things cluster together? They seem totally separate.
Well, the thinking, based on the sources, is that there might be an underlying, maybe systemic issue, perhaps a generalized weakness in connective tissue throughout the body, or maybe some kind of widespread problem with smooth muscle function or motility in the digestive system.
So like a background condition that makes you prone to all 3.
Potentially. Things like obesity and getting older are known risk factors for all 3 conditions independently. So Saint's Triad might reflect this kind of systemic wear and tear or breakdown in the structural integrity of the abdominal tissues, allowing stones to form, hernias to occur, and diverticula to develop. It's quite fascinating.
It really is. Okay, so bringing this all back to you, the listener, we started with something super common, heartburn. But we quickly saw that the underlying cause, structurally, can be really complex. The absolute key takeaway has to be understanding the difference between those 2 main hernia types. The sliding hernia, that's mostly about chronic chemical damage from acid reflux.
Manageable, often conservatively.
Right. But the rolling hernia, that's a completely different story. It's about acute mechanical risk, the danger of strangulation, even without any reflex symptoms.
And that structural difference dictates everything about the approach, from potentially just lifestyle changes and meds for one, to often needing immediate surgery for the other to prevent a disaster. That's the single most critical distinction here.
Absolutely. And it really makes you think, doesn't it? The sources show us that the rarer, more acutely dangerous condition the rolling hernia presents without that classic warning sign of heartburn.
Yeah, it's kind of sneaky.
It is. So the final thought we wanted to leave you with is this. What other common, maybe seemingly minor symptoms, like you mentioned, perhaps just persistent hiccups or occasional palpitations, might actually be masking a really significant, potentially dangerous underlying mechanical issue somewhere in the body? Something to definitely mull over.